Thank you. I'll try and keep it short and simple. I get the benefit of having audience from both sessions. I guess just to mention that getting 6 by 6 is no longer utopian, but if the other eye is something like this, then the best of cataract surgeons might not find it that easy. And broadly, when you look at corneal surgeons, they do deal with epithelial, stromal and endothelial disease, and when you're looking at managing the corneal part, it needs to be done similarly. This patient with rheumatoid arthritis, Schirmer's of 1 millimeter, and an ocular surface disease index of 61. He's a biochemist by profession. He underwent some PI. He complains of dry eyes. And he says, whenever I cry, I don't get tears, doctor. So I said, you're 55, why do you cry? He said, my wife beats me. I said, I understand, I have similar problems. And in those patients, you need to optimize the ocular surface. And we use something called a smart plug. It's made of acrylic. And it's not very difficult to insert. And the advantage is with that, you can actually do this before surgery. So always remember, you need to optimize the ocular surface before you actually go with the lens. And doing a Schirmer's or at least putting fluorescein in slightly older patients is a good idea. Remember that a lot of them already have borderline ocular surface disease, and once you actually give them a lot of drops post-operatively, you can have corneal melts also. In SICS2, you can have a lot of epithelial problems, and remember that you need to work these patients up at least for some kind of autoimmune disease, ask for their medications, and do at least a Schirmer's or a fluorescein. I use something called an ocular surface disease index questionnaire, which kind of helps. And when you look at corneal opacities, they can be full thickness, they can be peripheral. And I think I would just conclude my, Ellen, I'll conclude. I think the next set is there. My battery's also gone down. I think it's an indication. Yeah.